Looking for my admit all. Good evening. Welcome to Spine Time. Dr. Jotwani, please begin.
Okay. Hello, everyone. Welcome to our bi-weekly webinar called Spine Time. Today's topic is when to see a pain specialist. And I think it's a really exciting topic. Many folks can't really conceptualize why we have an entire field of medicine devoted to a single symptom. People know that there are eye doctors, they know that there are brain doctors, but a lot of patients are sometimes really interested to know, like, how did pain medicine, which is a symptom, become its own specialty? So we hope to answer some of those questions for you today. Today I'm joined with two of my really fantastic colleagues, Dr. Petro and Dr. Pak. As some of you who have watched these webinars in the past know, this is coming to you from the Center of Comprehensive Spine Care. Really, it is a labor of love and also interconnectedness between various specialties of medicine, between spine surgery, neurology, rehab medicine, complementary medicine, mindfulness-based stress reduction, and CBT. So what we are calling, integrative medicine, and then us as well, pain management, all working together to take care of patients. As I mentioned, I'm joined today by two really fantastic colleagues of mine, Dr. Pak and Dr. Petrou, both of whom trained as anesthesiologists before completing fellowships and subspecialization in pain medicine. Dr. Pak, was a resident here and went on to do a fellowship at Harvard University. Dr. Petrou was both a resident fellow at Stanford. So they both bring really interesting new perspectives to the Weill Cornell spine family. So with that, I'm going to allow Dr. Pak to begin to sort of tell us a little bit about what is pain medicine and what exactly you should be seeing a pain doctor for.
So thank you, Dr. Jotwani. It's a very question that we get is what does a pain management specialist do? And in pain management, we really provide patient management for all kinds of pains, kind of in the name. Now, there are a variety of different types of treatments that we provide and different types of conditions that we treat. We work as a part of the Comprehensive Spine Center. So certainly spine-related pain issues, whether it's neck pain, low back pain, et cetera, is certainly something that we see plenty of. Having said that, we do also treat patients with pain elsewhere. So for example, patients with sports medicine issues, joint-related pain. We have a very comprehensive cancer pain program here at Weill Cornell, as well as many of us who also treat pelvic pain, headaches, different types of nerve pain syndromes, and also central pain syndromes such as fibromyalgia. So really all of those things fall within the umbrella of pain management. Now, we have specialists on the inpatient and the outpatient side. So if many of you have been seeing providers at the clinics, that's obviously in the outpatient setting. We also have a service that covers the inpatient pain service at the main hospital 24/7. And so really, we do see patients in all different types of clinical settings. But certainly, as you can see here from the chart, pain is one symptom. However, it can really pervade other aspects of your life and cause issues in many different areas, right? So there's a very close relationship with pain and also, for example, mood disorders, sleep issues, issues with being able to do the things that you enjoy doing, whether that's hobbies or even your activities of daily living. So pain, if it becomes a problem, really pervades all aspects of life. And it's our job to not only help you with treating the pain symptoms, but also as a proxy of that, being able to help you with quality of life. And I think that that's what we see our goal as pain management physicians is being. Next slide. So the question that we get quite commonly is then what can you do? What can you do for me? And what kind of treatments can you provide? And that depends on the specific condition that you are trying to treat. I said that I think they fall under these categories. And so we use a lot of different tools in our toolbox, one of which is certainly medications. And that ranges from anti-inflammatory medications, different types of muscle relaxants, nerve pain medications, depending on your condition. So those are things that we oftentimes use to employ. Now, in addition to that, we really try to use a multimodal approach, meaning not just one type of therapy, but attacking the pain from many different fronts. So that includes using things like physical therapy. And so we'll oftentimes provide specific physical therapy regimens for our patients, injections and procedures when they're also appropriate for the patients. And so for those patients who have come to us for example, sports medicine issues or spine problems, oftentimes we're able to provide treatment directly at the source of the pain in a way that doesn't involve medications. Also, what I wrote here was CAM therapies, and that's short for complementary alternative medicine therapies. This includes using therapies like, for example, more Eastern medicine techniques, including acupuncture, things like medicinal marijuana for patients who are appropriate for them. Some patients are looking specifically for dietary, for specific dietary advice. And so these are also things that we can try to direct patients to in terms of resources for that. I know Dr. Jotwani, one thing that he's been using is also the use of virtual reality as a method of providing therapy for patients. So really using all of these different modalities and different types of treatments to help patients, not only from a pain standpoint, but also improving their kind of, functionality, their mobility, et cetera. And one other thing I put on here was also behavioral therapy. And so these aren't necessarily all things that we do personally. Having said that, in a lot of ways, it's also our job to be able to direct our patients toward the appropriate specialists and also providing them with the resources to really treat, every aspect of their pain syndrome.
Thank you so much, Dr. Pak. If anyone has any questions in the middle, I have the chat message board up. Feel free to chime in. If you have time for us, Dr. Pak, I do have maybe a couple of follow-up questions before we move on to Dr. Petrou. It's kind of interesting that most of us who are in the pain management field come at this initially as being anesthesiologists, but then we go through this extra training. And people might be interested to know, how does an anesthesiologist really, dive deep into some of these other things that can't seem to, have a lot to do with anesthesiology. And I think that comes down to, the kind of training that we get during our fellowship, which is fairly well-rounded. So I thought maybe you guys wanted to comment on what that training might be, for us as pain specialists.
Yeah, so, as a part of your training during the fellowship year, it's very different from what we do as anesthesiologists. Now, I think a lot of the basic skill set still transfers over. So from a procedural standpoint, and also just the understanding of basic mechanisms of pain, et cetera. The fellowship year is really designed to, I think, tailor that and also fine tune it to be able to treat a lot of these other types of specific pain conditions. And then there's also not only that, but also the utilization of a lot of these other types of therapies at our disposal, right? So as an anesthesiologist, we don't necessarily learn a lot about kind of complementary alternative medicine techniques, but certainly that is something that we become more attuned to as pain management specialists. And one thing I will certainly say is that the field of pain medicine, which is still very young, is constantly changing. So The therapies that we have available now are radically different, I would say, from even what was available 10 years ago. And that's also what has kind of kept me on my toes as a pain management specialist, and was one of the things that drew me to the field, was just kind of the ever-changing nature of how we treat pain. Because it used to be that a lot of our resources were more towards medications and providing patients with different types of medications for their pain syndromes. But what we know is that those medications come with a lot of side effects and a lot of potential other issues. So how can we treat patients in other ways that directly address kind of the underlying cause of their pain without providing them with a bunch of medications? And in some cases, I think it's appropriate, but only providing them with medications that just kind of treat the pain and doesn't get to the underlying source, if that makes sense.
Yeah. There's a question here in the chat. Whom to see when diagnosed with CRPS? What are the best treatments for CRPS? So I'll throw that out to either Dr. Petrou or Dr. Pak.
I'm happy to start. So I echo that, pain specialists are helpful for complex regional pain syndrome. That's the definition of CRPS. In terms of treatments, I think, I think that's why I like to go back to Dr. Pak's slide in terms of what pain management offers, because essentially we work in conjunction with, physical therapists as well as, our integrative health colleagues. So in terms of treatments, I do encourage each individual patient to speak with a pain provider to be able to tailor an approach. I think in terms of kind of large categories, so there are medications, so typically the gabapentinoids, the tricyclic antidepressants, the SNRIs, also things like bisphosphonates can be used. In terms of, we also talked about interventions. I think Dr. Pak kind of gave that nice timeline on terms of we have basic procedures and then more advanced procedures where there's more exciting information or clinical data that's suggesting utility. So when we talk about like advanced procedures, we're looking at something like peripheral nerve stimulation, especially for complex regional pain syndrome that's defined within a suspected nerve distribution, as well as things like DRG stimulation or spinal cord stimulation, versus kind of more of our some of the basic injections that we do, such as lumbar sympathetic blocks or stellate ganglion blocks. And then, for complex regional pain syndrome, I think, again, to kind of echo what Dr. Pak demonstrated in his slides in terms of how we coordinate care, physical therapy is particularly important, especially things like mirror therapy.
And then a question just came up: does Weill Cornell have in-house physical therapists or physical therapy department? And I'd say yes. Yeah, the answer to that is we do. So, to go back to what Dr. Petrou and Dr. Pak are both saying is that I really like to think of us, I don't know how you guys see it, but I like to think when a patient comes and sees pain management, what they're really getting is a head coach for their pain. Somebody who's going to be able to, exactly what you're saying, Dr. Petrou, really coordinate between all the various parts of this hospital that treat pain, because no one doctor owns pain medicine. I always tell all my patients, pain is probably the number one reason why people see a doctor. So pain doctors can't treat every patient in every aspect of their pain, but we are like the head coaches. We are able to say, okay, let's coordinate with physical therapy in-house or external for this patient for this reason. Let's combine this with, acupuncture from this part of the hospital. Let's kind of put this all together for people in a plan. And so the answer to your question, very roundabout way, is yes, we do have in-house physical therapists. And then the follow-up to that is, where does massage and pressure point therapy fall in the pain management specialty? I'd say it falls into that, that category of alternative medical therapies that Dr. Pak was mentioning. We definitely work with our patients to find some of the best, ways in which massage and other types of alternative therapies can be helpful.
And one thing I also wanted to emphasize was that, with everything that I mentioned in terms of the tools at our disposal and all the different things that we can provide for patients, it's also our job to be able to tailor those treatments according to every patient's preferences, right? So there are certain patients who come into our office and say, look, I really don't want to pursue any kind of interventions or interjections. I'm more interested in, let's say, some of the even more conservative stuff, right? So in that case, it's our job to be able to take that into consideration and say, okay, well, if we're not going to do injections, then these are the other therapies that you can potentially utilize, and that may help you. And then conversely, we have patients who come to us and say, look, I've done the physical therapy, I've done some of the medications already, and this has been going on long enough, so I'm really interested in intervention. So in that case, we will focus more of our efforts more towards the intervention side. So it is really our job to be able to listen to the patient and provide them with the appropriate treatments in accordance with kind of what their preferences are. And so that's what also makes, I think, us unique is being able to provide really tailored treatment, because there are so many things that can be provided.
That's true. I think all of us in pain medicine realize that, our relationships with patients, rarely are they ever one-offs. It's usually a journey. We're usually taking a journey with our patients and discovering together the ways that get them back to that quality of life that Dr. Pappas mentioned. Now, I want to be cognizant of the time here. Dr. Petrou has some great slides that he wants to present, and I'm paying attention, and we'll get back to those questions coming in from the chat line. So Dr. Petrou, why don't you take it away?
Excellent. So you can see my slide here focuses mostly on back pain, in this case, low back pain. And I do this just because I think, I agree with Dr. Pak's excellent framework of all the different pain areas that we treat. But since we are a spine center, most patients initially when they come to us will be looking for a physician to address their low back pain. In particular, we're most helpful when that low back pain is, more greater than 6 weeks. And that's when we look at things that where or treatment or diagnoses that we can offer, medication, procedural management. So I think first, if we look on the left side, when we're looking at the spine model here, we're looking at kind of the vertebra, the spinal cord and the nerves, the facet joints and the muscles. When we talk about where pain generators can be, they can be in the vertebra, they can be in the muscle. You got a recent excellent spine time on Intracept or the basovertebral ablation, as well as there was also an excellent spine time in terms of multifidus, looking at Reactivate. And then we also look at things like myofascial pain or musculoskeletal pain, where we talk about, you might hear some of discussing like trigger point injections. Then we also look at the top figure here, where we're really focusing now on the spinal canal. And at this point, ideally, it's always excellent if the patient has imaging, particular X-rays or MRIs. I always counsel patients that we can always be most helpful when we actually see the images ourselves, rather than just relying on a radiologist report. But here at the top, you can see, common diagnoses. You might hear something like spinal canal stenosis or things like neuroforaminal stenosis. And this is where we talk with patients. You might hear things like a disc bulge that ends up causing some irritation at the spinal canal. We then talk to patients about their symptoms, and I think again Dr. Pak excellently points out how each patient is individual. So we focus not just on the imaging, not just on lab reports, but listening to the clinical story and understanding where is the patient's pain. Is it radiating down the leg, or is it focused on the back? And at this point, you might hear us when we talk about, neuroforaminal stenosis versus, essential disc herniation and spinal canal stenosis. And then lastly, kind of, again, addressing some of the bread and butter issues where patients, when they come to us, in the initial visit, we'll talk about arthritis in the spine. So, previously you heard how there are other, joint arthritis, knees, hips, shoulders. Well, in the spine joints or the facet joints, that can also be a source of back pain. And we discuss with patients, in terms of interventions, medications, as well as, physical therapy exercises that are important to help address those symptoms.
Thank you so much for that. So we do have a couple of questions. Somebody wrote, that they've been trying a lot of different types of injections and ablations, also doing Tai Chi, and nothing's helped. They are already working with the rehab department. Should they come to see us? What do you think, Dr. Petrou?
So I think that we work very much hand in hand with all our colleagues, and I think that's why Dr. Jotwani, addressed that in the beginning in terms of, we're a family here at Cornell. We work very closely with the colleagues in our different environments. There are many things we overlap with rehab. There are certain procedures that we have a little bit more experience in. What I would say kind of as a first point is to ask the rehab doctor initially what are the best steps, what are their recommendations? Because, again, there's something they will refer patients to the pain management clinic with specific things that they would like us to help address.
Yeah, exactly. There's a little bit of overlap. Like I said, no one field of medicine owns pain medicine, even though we are pain specialists. Other doctors deal with pain too. A lot of them can do the same things that we do. Sometimes we may have a difference in our approach. Sometimes there may be something that we can think about a little differently, but we look at it as a collaboration. So if you think that you may benefit from a pain medicine specialist, and you're really looking at it as kind of a second opinion, always best to start by just talking to your rehab doctor and seeing, oh, hey, do you think, that's a good or appropriate referral? Because we're available, but, we are working in tandem with those departments as well. Somebody else mentioned, are CAM therapies covered by insurance? And if not, why not? One of the great questions, of our medical universe, how to answer why insurance companies may not cover things like acupuncture or massage. Dr. Petrou, any thoughts?
So correct me if I'm wrong. So my understanding is for Medicare, I don't believe there are any more restrictions on the amount of things like physical therapy per year. And then Medicare for axial low back pain, I do believe covers acupuncture. Private insurances, I think that's less. I think that's less likely. It also depends on, I think there are categories of when we look at complementary alternative therapies. So, when we look at medications, so things like alpha lipoic acid, which is, not FDA approved, but there is some clinical data that suggests that can be most helpful for things like diabetic peripheral neuropathy.
Right.
Without that FDA approval, then no, unfortunately, those don't get covered. But I will say other things like our integrative health colleagues some of the classes that they hold that should be covered by insurance.
And we see this changing. I mean, just yesterday, as Dr. Pak mentioned, I'm sort of a proponent of virtual reality therapy for pain. Just yesterday, CMS, which is the Center for Medicaid Services, contracted to allow access or look at a virtual reality headset as a medical device. So these things are constantly in flux, and things that may not have been covered last year might be covered this year. So it's always worth asking the question, I think. But we hope to see more and more alternative medicine therapies covered because they do provide patients relief, and sometimes at very, very low side effects. And just one more note, if you do have your hand raised, I don't have the ability to really give you the floor, but if you type a question into the chat, I'll do my best to try and get to it. Perfect. So somebody asked, are you able to distinguish the difference between how pain manifests from facet joint issues as compared to nerve compression issues? What do you think, Dr. Petrou? Do you think we can suss that one out when a patient comes in?
So I think that's why, going back to what I think was said earlier by Dr. Pak, it's the importance of the patient interview, and again tailoring to the individual patient. So that's why we take a clinical history. We don't just treat imaging. So to understand, so some of it when looking at like facet versus like nerve compression, so things like spinal canal stenosis or lumbar radiculopathy. One, we do a history and physical. So looking at, where exactly is the source of the patient's pain, how they describe the pain, where does it travel, what activities worsen the pain or improve the pain, what physical therapy interventions have they done that either improve the pain or worsen it. And then second, then next looking at physical exam maneuvers. So that's why, we are, given the era of COVID, we want to be as most helpful as possible. And we do offer video visits, but that's why you will see our attempts to do physical exam maneuvers virtually with the limitations that we face. But that's why also things like, sometimes if we don't have that new patient visit, in person, we might recommend that you have a follow-up in person because the physical exam maneuvers that we do can help us delineate between facet joint versus a lumbar radiculopathy. And then lastly, we do obviously take everything into consideration. So imaging is important and will help differentiate between the two.
Exactly. We do, Dr. Petrou and I, we do have the privilege of training medical students, residents, and fellows as part of our practice. And I often tell all those folks when they're working with us, patients will tell you where their pain is. Their stories, their exams, like actually laying hands on patients. I think that's something fairly still unique about our specialty, which is in order to come up with the right diagnosis, almost always the patient's story, the way they describe that pain. Oh, it feels like a very electric pain versus, oh, it feels like a throbbing in my back. Those things have such meaning for us as pain doctors and the way that we interpret people's stories. Or people will say things like, oh, my pain is worse when I'm walking upstairs versus my pain is worse when I'm doing a specific thing. We're really looking out for those things. And I think a part of it is we have that training and the experience to decode some of that. But it all comes from talking to the patients. And you're right, not treating people like they're walking MRIs. Now, one more question. What are trigger point injections and how is it different from ablation injections? Fundamentally, I think they're very different. What do you say, Dr. Petrou?
So what I try to explain to patients in terms of trigger points, the idea is that the muscle fibers are very tight and the goal of the trigger point is to help loosen the muscle fibers. That being said, those muscle fibers can get tight again and cause, again, that myofascial pain. So physical therapy ends up being very important. And what I try to explain to patients is the goal of the trigger point injection is to help the patient engage in physical therapy so those muscle fibers don't get tight again. Ablation is a little different. I will say it also depends what you mean by ablation. So for the most part, I think we talk about ablation in the category of like facet. So medial branch radiofrequency ablation. So that's where essentially the medial branch nerves that innervate those facet joints are the source of the pain. And we talk about ablation, we're burning that medial branch. It is safe to do, and that that can provide up to 6 to 9 months of pain relief. However, to kind of expound on ablation, so we also have genicular nerve ablation. So for our patients who have chronic knee pain, especially in the anterior segment, who either had knee surgery or not candidates for knee surgery, we can target the genicular nerves, and again, we can do what's called cool leaf ablation. We do that gentle warming. And then lastly, ablation, any nerve can in itself be ablated, but that ends up being a more individual conversation and exactly where the patient's pain is.
Right, exactly. We have, okay, great. It looks like we answered all the questions. Very good. So ultimately, Dr. Petrou, now that we've gotten through a lot of the questions from the audience, where do you see pain medicine going? You know, what do you think our specialty is going to, because what we've talked about today is covers so many different things. You know, we've talked about everything from psychotherapy to nerve ablations and all these very specific procedures. It's almost unreal to think that one specialist can do so many of these different things, or can help coordinate care amongst all these different things. Where do you see our specialty going in the next 5 to 10 years?
I think that's an excellent question. I think it really speaks to what we talked about in the beginning in terms of the fundamentals, and how part of the fundamental of being the pain specialist is continuing to advance the field and essentially continuing to come out with new devices that can help address pain, especially as our patient population is older, has more health problems, where they're really cannot be considered good surgical candidates. So I think that's why one of the really nice things about the Spine Time seminars is that we have basically a forum to share those new interventions, so that things like peripheral nerve stimulation, as well as things like the Reactivate device, which again, I think both had recent Spine Times. I think that being said, it also does, I think that where the future is of pain medicine also relies again on the fundamentals in terms of how we work with our colleagues, how we, work with physical therapy, working with integrative health, where, I think for the most part, we're not relying as much on epidurals. We're just, every patient, it used to be that in pain clinic, like every patient got an epidural, and that was essentially why primary care referred patients. And now we're really tailoring the approach, I think, in terms of, again, with the advanced procedures, but also being able to identify and connect with the physical therapist with the integrative health.
Exactly. I want to just echo that. I do see it as every year we're learning more about, what pain is and how we treat pain, and how do we, treat pain in a way that's sustainable across time. There's just this new question: how often can you safely have injection for severe osteoarthritis of the knees? And I'd say probably the answer to that question 20, 30 years ago is very different than how we think about that answer today, right? Because we have now so many different kinds of injections for severe osteoarthritis, and we're working in combination with our orthopedic surgeons to decide, how many injections is enough injection. So if corticosteroid injection, right, which is the injection that people have been doing for many, many decades now. I don't know about your practice, Dr. Petro, but I would say 3 to 4 times a year is probably my limit, because we've learned so much about steroid, and we know that exposure of steroid to the same joint over and over again actually furthers degeneration. So it makes you feel good for today, but in the long term, it's not healthy for your knee to keep getting too much steroid.
Agreed.
But now we also have other techniques, like you were mentioning, genicular nerve blocks, where we can still provide pain relief to the knee without having to engage with those same side effects. Very good. And I think we have probably time for one more question from the audience. So the last question is, can pain management help bone-on-bone arthritis in the knee, or surgery needed for them? I've tried injections and it doesn't help. What do you think, Dr. Petro?
So I preface this where, again, I think I would speak with a pain specialist to address individual cases.
Of course.
I think we work pretty in conjunction with our orthopedic surgeons for when patients are considered not surgical candidates, or if they have other comorbidities or for other reasons. That's where we I think it ends up being a collaboration. I think also, this is where it just kind of repeats what Dr. Jotwani was getting on. We are moving away from just, intra-articular injections, and that we have things like the genicular nerve blocks. So I think there's a role for pain management. I think that conversation has to be one who will address the patient as the individual, as well as look at imaging. And then again, I can say that I, for one, am always amenable to speak to other providers. If a patient, who's coming to me says, I had this provider, this surgeon wants to operate, I make myself very available to collaboration.
So great. And I think that's our time for today. Thank you everyone for being here. So at this point, I think we can close this out by saying that, pain medicine is an exciting and broad field. There are lots of reasons to see pain doctors. If you want to learn more about pain medicine, you can visit the website, and you can call to make an appointment, but, ultimately engage your fellow, your primary care doctors, your surgeons, whoever it is that, if you think you may want to see a pain doctor, reach out to other doctors in your network to see whether or not they think it's a good idea as well. And, we're happy to take care of anyone who comes. As you can probably tell, we have such a broad sort of set of tools in our toolbox that we're happy to try and find the right tool for every patient. Thank you, everyone.